Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome back to yet another primary snippet. So, before we dive into snippet, how are you, Maddie?
Yeah, I'm good.
It's exciting, isn't it? Like our primary was just 3 weeks away now, and all the best to all the candidates who are appearing for was soon.
Yep, good luck. Hope it goes well.
Yes. So today's snippet is about left ventricle. So describe the consequences of the healthy left ventricle of a sudden and sustained increase in afterload.
So I divided this up into consequences for volume, pressure, work, coronary perfusion, reflexes, heart rate, cardiac output, and then some sustained effects. I did get a bit of insight on this question from Naomi, who is the current chair of the primary exam, so a bit of inside information. So in terms of volume, the aortic valve closes earlier when there is an increase in afterload. So there's a decreased velocity of the myocyte fiber shortening, and then there's therefore decreased stroke volume and increased left ventricular end systolic volume. Because of this increased left ventricular end systolic volume, venous return is then added to this increased amount of volume, and this increases the end diastolic volume. So if this is a healthy left ventricle, the stroke volume therefore will gradually return to baseline as it now has an increased volume to play with. In terms of the pressure, there's decreased velocity of myocyte fiber shortening, which initially decreases stroke volume, and so there's an increased left ventricular end systolic pressure. There's also the increased left ventricular end diastolic volume, as we just spoke about. So there's an increased left ventricular end diastolic pressure. And I have included a bit of a diagram from one of the anesthetic textbooks, which kind of hopefully helps to clarify some of this information, which will be available in the show notes. In terms of the work, the myocardial oxygen demand is very closely linked to afterload. So increased afterload will increase the myocardial oxygen demand and consumption. And so the myocardial work does also increase. From a coronary perfusion point of view, we know that the coronary perfusion is highly autoregulated and it's very tightly coupled to myocardial oxygen demand. So as the myocardial oxygen demand increases, it will try and match this. So it should remain stable acutely. But however, in the longer term, there is a risk of subendocardial ischemia due to a hypertrophied left ventricle. From a reflex point of view, the baroreceptor reflex will only kick in if the increased afterload is associated with an increase in arterial pressure, which isn't always the case. So if there's stretch on the carotid baroreceptors, there's increased firing of afferent nerves through the carotid sinus and the glossopharyngeal nerves to the medulla, and there's decreased sympathetic activity and increased parasympathetic activity. So therefore, a decreased systemic vascular resistance, contractility, and heart rate. But this won't always kick in. In terms of the heart rate, there can be differing effects depending on what the afterload is associated with. So if the heart rate might increase if the stroke volume remains low and results in a decreased cardiac output and decreased blood pressure, as the decreased blood pressure is detected by the baroreceptors. But the heart rate might also decrease if the increased afterload is associated with an increased arterial pressure. And from a cardiac output point of view, because this is a healthy left ventricle, the cardiac output is going to initially remain the same. So the increased afterload will cause an increased end diastolic volume or preload, which activates the Frank-Starling mechanism. And this increases the contractility, which will compensate for the reduction in stroke volume from the increased afterload. And there's also something called the ANREP effect. So a sudden increase in afterload will cause an increased ventricular inotropy, which is initially via the Frank-Starling mechanism. If this is maintained for a longer period of time, approximately 10 minutes or more, the contraction force increases even more. And the actual physiological mechanism by which this occurs is uncertain, but it's thought to potentially be due to an increased calcium load due to the activation of channels or reverse sodium calcium exchange. And we know that calcium is one of the main players involved in increased inotropy. In terms of a sustained effect, the sustained increase in afterload activates genes in the ventricular muscle, and these are also the genes involved in growth. And so there's left ventricle concentric hypertrophy. So we do see this in patients who classically have significant hypertension, and they do get a hypertrophied left ventricle. So the hypertrophy causes increased wall thickness and decreased chamber diameter. And this reduces the internal wall stress, but decreases the ventricular compliance, which can eventually lead to diastolic dysfunction, impaired myocardial blood flow especially during periods of stress, and increased left atrial pressure. But these are all sustained effects. These don't happen acutely.
Thanks, Maddie. So I guess what Maddie demonstrated there was having a structure helps you to think it through and then answer this question properly. Because obviously, when you see this question for the first times, you freak out or suddenly get frozen and don't know what to write. But if you break it down in terms of what it will do to end diastolic volume, what it will do to end diastolic pressure or coronary perfusion or work, then you start thinking it more clearly. Also, the question can be asked in a different form. I guess what happens if you receive a bolus of noradrenaline or metronidazole, and that will be probably the similar territory where examiner wants you to take into. Now, shout out to Naomi for guiding you. Also, she's doing a great job as a chair of primary. So thanks, Naomi.
And I think this question is also tricky because it's not, you can't find the answer in one particular textbook. It's using like physiological principles from multiple like different sources that you might come across and then trying to apply that to a clinical scenario. So it does require a bit of thought. And I think, like you said, a structure does help you to at least try and think these things through.
Yeah, I agree. I think that's why having these answers now available to candidates will obviously help to answer this same question in future. So thanks, Maddie. So that's the end of our today's snippet. We'll be back with another snippet in week's time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.